The following podcast is part of a certified educational activity titled Improving the Management of Chronic Rhinosinusitis with Nasal Polyps, Practical Strategies for Selecting the Right Patients for Targeted Treatment. Access the entire activity and complete the post-test at peerview.com/ERM860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Stella Lee from the University of Pittsburgh in Pittsburgh, Pennsylvania. Welcome to this unique case-based educational activity on the management of patients with chronic rhinosinusitis and nasal polyps. This activity will give you the opportunity to explore strategies for selecting appropriate therapy for patients with CRS with nasal polyps, and in particular, determining which patients are candidates for targeted biologic therapy. So let's get started and see how management decisions can change based on variable patient, disease, and treatment-related factors. So what is chronic rhinosinusitis? We know this is an inflammatory condition with multiple phenotypes. We have to have at least greater or equal to 12 weeks of symptoms, including drainage, nasal congestion, facial pain or pressure, or decreased sense of smell, as well as one objective criteria, including nasal endoscopy showing drainage or mucosal edema, polyps, or a maxillofacial sinus CT scan showing inflammation of the paranasal sinuses. We have a better and more granular understanding of uncontrolled severe CRS. So as you can see here on this slide, if you have uncontrolled disease, patients often need long-term intranasal corticosteroids and even systemic corticosteroids in the preceding 2 years and or previous sinonasal surgery. Patients who have severe disease include patients who have bilateral disease with a nasal polyp score of greater or equal to 4 and persistent symptoms despite long-term intranasal corticosteroids with a need for add-on treatment. And you can see some of the different symptoms associated with CRS nasal polyps, including loss of smell, nasal congestion, and SNOT-22 scores that are greater or equal to 35 points, and a total symptom VAS. So these are different ways you can measure symptom severity. So patients with CRS can be classified as either with or without nasal polyps. 20% of CRS with nasal polyps in this category, patients have high tissue eosinophilia and a predominantly type 2 inflammatory process. 80% of patients have CRS without nasal polyps, and this is more of a Th1 predominant inflammatory process with less eosinophilic infiltration. Just keep in mind that there is a range of disease phenotypes as well as endotypes, and it's important to realize that there is a spectrum of disease. Past reactions to any NSAIDs should be evaluated for possible diagnosis of AERD, or aspirin-exacerbated respiratory disease. Is this CRS with nasal polyps? Patients often have loss of sense of smell as well as nasal congestion, and these two particular symptoms are more classically associated with CRS with nasal polyps. Recent evidence also suggests ear pain, sneezing, severe difficulty breathing through the nose, severe nasal congestion, and bothersome loss of taste and/or smell were significantly more likely to be reported in patients with eosinophilic nasal polyps. Comorbidities such as asthma and allergic rhinitis are also common in patients with CRS with nasal polyps. Patients with CRS with nasal polyps have a significant impact on quality of life, and as you can see here, there are impacts on both physical and psychologic domains. Nasal symptoms include blockage and congestion, postnasal drainage, loss of sense of smell and/or taste, cough, aggravation of asthma, as well as ear symptoms, including ear congestion and pain. Neuropsychiatric symptoms include anxiety, depression, as well as difficulty with sleep, which also leads to daytime fatigue. And if you look at some of these studies done on CRS with nasal polyp patients and their quality of life, they have significant impact on their physical as well as mental components. And if you look at their comorbidities, including asthma and patients who have aspirin-exacerbated respiratory disease, which here is shown as NERD, or NSAID-exacerbated respiratory disease, these patients have worse physical and mental outcomes compared to patients who do not have CRS with nasal polyps and or the corresponding asthma and AERD. So let's go to our patient Jim, who's 35 years old. And this is a common presentation of patients who have CRS with nasal polyps. They often present to us as adults. Patient works in construction, and he suggests that the symptoms that are really bothersome to him are nasal congestion, impaired breathing, and he's unable to smell for at least the past several months. He has now trouble sleeping and subsequently his ability to do his job effectively. He also has concomitant asthma and received 2 courses of systemic corticosteroids within the past year. He's on daily ICS LABA and bronchodilator as necessary. Other exam notes here that are important, that nasal endoscopy shows bilateral nasal polyps, and his CBC with differential shows that his eosinophils are elevated with an absolute count of 350 cells per microliter, and his IG is also elevated at 112. You have chosen a scenario with a decision point of determining what type of medical treatment is appropriate for Jim, and a complicating variable of Jim wanting surgery to cure his nasal polyps. It is important to really engage patients in shared decision making, especially in these complex diseases that are chronic and do not have a cure. So this involves inviting the patient to participate in the decision and presenting all the options to the patient, including the risks and benefits of each option, and then helping the patient to make that decision. And those topics to discuss including different medications, the surgical options, the comorbidities the patient might have, the symptoms that are really bothersome to the patient, how this disease is affecting their quality of life, and the adherence to different medical options. Also very important to realize is that surgery is not a cure for nasal polyps. Polyp recurrence is very common after sinus surgery, and studies have shown that polyps often come back as early as 6 months after sinus surgery. As you can see here, 35% at 6 months, and as you go to 40 at 18 months, you even have up to 40% recurrence after surgery. Patients who have had surgery and do not consent to repeat surgery often have poorly controlled nasal and sinus symptoms, and they continue to suffer with these symptoms for long periods of time. Type 2 inflammation is clearly associated with more severe sinus disease and symptoms, and also recurrence after sinus surgery. So let's go back to Jim. So we explained to our patient that surgery will not cure his nasal polyps, that this is a chronic condition, and that the polyps are likely to recur afterward, after surgery, and possibly necessitating additional surgery. And furthermore, if surgery is the option, it should be done in conjunction with medical treatment, because sinus surgery alone without adherence to topical therapy afterwards likely will not be a successful option for the patient. You have chosen a scenario with a decision point of determining what type of medical treatment is appropriate for Jim, and a complicating variable of comorbid asthma. So let's talk about traditional treatment approaches to CRS with nasal polyps. Nasal saline irrigations are a mainstay in the treatment of CRS with nasal polyps. Topical intranasal steroids are important as long-term treatment, and there are several methods to deliver these medications into the sinuses. Antibiotics are controversial and may be useful in treating infectious exacerbations, but evidence of clinically significant efficacy is lacking. Leukotriene modifiers such as montelukast may be helpful, and systemic steroids should only be reserved for exacerbations due to significant adverse effects. Short courses of oral corticosteroids for CRS with nasal polyps can result in short-term improvements, but long-term efficacy is often not present. There's an interesting study that showed that at 3 to 6 months after the end of the oral steroid treatment period, there was little or no improvement in quality of life or symptom severity for patients taking an initial course of oral steroids compared with placebo or no treatment. As we know, oral corticosteroids can have significant adverse effects. As seen here, patients can have neuropsychiatric side effects, glaucoma, cataracts, fractures, growth suppression, infection, adrenal insufficiency, as well as osteoporosis, as well as skin breakdown. And these are just some of the side effects that can occur with oral corticosteroids. Type 2 inflammation is fundamental to CRS with nasal polyp pathophysiology. And let me walk you through this slide a little bit. We know that in patients who have CRS with nasal polyps, they often have a barrier deficiency. And this can occur to various insults that occur to the epithelium. Once this occurs, there is an immune dysfunction that occurs. And as you can see here, IL-4, 5, and 13 are secreted by ILC2 cells, and that results in a cascade of inflammatory cells and effectors and mediators, including the recruitment of eosinophils and B cells that then secrete IgE and activated mast cells. And these cells all feed back upon each other, and it becomes a localized inflammatory process that is self-sustaining. And at this point, we still don't quite understand this pathophysiology, but we are getting more sophisticated in developing targeted therapies to those particular cytokines that we know are causing some of these problems, such as you can see here, IL-5 blockers, as well as IL-4/13 inhibitors and IgE inhibitors. So here we see IL-5 blockers including mepolizumab, reslizumab, and benralizumab, and Dupilumab, which blocks both IL-4/13 by blocking the IL-4 receptor alpha, and as a result is able to block both IL-4 and 13 at the same time. And then the IgE blocker Omelezumab, which then blocks free IgE. This is a table that shows the different biologic therapies approved for asthma and in development for CRS with nasal polyps. Dupilumab was the first biologic drug approved for CRS with nasal polyps. Omelezumab was recently approved, and there are other drugs including mepolizumab, benralizumab, and fevipiprant, which are in development, and we're awaiting the data from these trials. Let's talk about Dupilumab. We know that the biologic is quite safe and effective in patients who have CRS with nasal polyps, and let me walk you through this slide. I think it's important to look at particularly at this nasal polyp score, where the purple line is the treated group and the orange line are the placebo patients. So as you can see here, the patients who were treated with Dupilumab had significant decrease in nasal polyp score, and it was quite a rapid decrease even at the 8-week point. Nasal congestion also significantly improved, and then as you can see here, when patients are off treatment, the symptoms do slowly start to come back, and this is at 24 weeks. Again, I think the important things to look at on this slide are Lung-Mackay is a radiographic outcome looking at the sinus CT scan and giving a score to the severity. So the patients did have improvement in their imaging severity, as well as improvement in their SNOT-22, which is a measure of symptom severity. It's also called the Sinonasal Outcome Test, 22 questions. And so patients who were treated had significant improvement in how they felt, as well as UPSIT, which is the University of Pennsylvania Smell Identification Test, which measures how well patients can smell, and the patients had rapid improvement in their sense of smell even as early as 2 weeks. So patients, overall, the nasal polyps decreased in size, their sinonasal outcome, their outcomes improved, they felt better, and they could smell, as well as their radiographic severity also improved. This is showing that at over 52 weeks, patients also continue to have improvements throughout that treatment period. And I think this is an important slide that shows, why we should think about perhaps alternatives to more surgery and more steroids. And because when you compare Dupilumab to placebo in this real world kind of scenario, which isn't quite real world, but I think it's important to realize that in the trial, some patients did end up having to need systemic corticosteroids or surgery, and the patients who were treated with Dupilumab had a significantly decreased rate of needing either of those things. Let's talk about Omelezumab. Omelezumab is a humanized monoclonal antibody directed against IgE. It has been approved for the treatment of moderate to severe allergic asthma, chronic spontaneous urticaria, and most recently for the treatment of nasal polyps. Omelezumab was evaluated in 2 phase 3 studies, POLYP 1 and POLYP 2, and for the treatment of adult patients with CRS or nasal polyps inadequately controlled by intranasal corticosteroids. And these are some of the results of POLYP 1 and POLYP 2. As you can see here, these POLYP 1 and POLYP 2 were basically the identical studies done in replicate. And both studies confirmed that there was a decrease in nasal polyp score. It was about, here you're seeing about a 1-point decrease And here, nasal congestion score was another outcome measure that patients in the treated group had significant improvement in their congestion. This is another slide showing how many points they improved. So a greater or equal to 2-point improvement, there was a subpopulation patient that had a significant improvement. And then if you look at greater than 1-point improvement, as well as their nasal congestion, the patients had significantly improved outcomes on Omelezumab compared to placebo. Another slide showing the outcome measures of SNOT-22 and an upsit, and what was significant was that patients who were treated with Omelezumab did have a significant improvement in their SNOT-22 over time compared to placebo. And overall, their total nasal symptom score as well, significant improvement in their in how they felt and as well as their medication usage. Mepolizumab is an anti-IL-5 monoclonal antibody previously approved for severe asthma with an eosinophilic phenotype, eosinophilic granulomatosis with polyangiitis, or EGPA, and most recently hypereosinophilic syndrome. Results from the phase 3 SYNAPSE trial showed that mepolizumab, when added to standard of care, demonstrated statistically significant improvements in nasal polyp score and nasal obstruction, as measured by VAS. Key secondary endpoint of time to first actual nasal surgery up to week 52 was also significant, showing a reduction of 57% versus placebo. And FDA approval is now pending for treatment of CRS with nasal polyps with mepolizumab. This is a slide showing that mepolizumab improved nasal polyp score, as you can see here with the orange graph bar showing that patients had improvement compared to placebo in gray. And these are the point improvement in nasal polyps score in proportion of patients on the y-axis. And on the other graph showing nasal obstruction as well. So patients had both improvement in their nasal polyp score and their nasal obstruction. How do we integrate biologic therapies into practice? I think it's important to realize that this is a complex decision-making process that if you have an immunologist or pulmonary colleague that you can discuss the patient with, that would be ideal. You can see some of these categories when we're thinking about a biologic therapy, including confirming the diagnosis of uncontrolled severe CRS with nasal polyps, as we had discussed earlier, and check for comorbidities such as asthma or NSAID ERD, also called AERD, and their consequences of these diseases. Check that type 2 inflammation is likely present. Inform the patient on various treatment options, the perspectives on these treatment options, and the risks and benefits of each one. And then also take the decision on surgery versus biologic therapy. We need to proceed with an informed patient. So that involves shared decision making. And then when you're selecting the biologic drug, we have to note limitations that are applicable for specific drugs. So I think overall it's very important to be educated on the mechanism of action and the potential side effects and benefits of each biologic, as well as comparison to surgery. And as I mentioned, CRS with nasal polyps and asthma, oftentimes these patients require a multidisciplinary approach and collaboration with an asthma specialist in order to select the best biologic drug for this particular patient. How do we define response to biologic therapy? We often want to follow up these patients regularly, and here, after 6 months of treatment, we can use some of these tools to assess how they are doing. So these are some of the outcome measures, such as sense of smell, nasal congestion score, nasal polyp score, SNOT-22, and VAS. And you don't have to necessarily use all of these, but these are available to us to assess our patients rather than just a qualitative, are you feeling better? So in general, if you look at this chart, you can see that if patients are doing better based on some of these outcome measures that are suggested, that perhaps we should consider continuing the biologic therapy. But if it's not acceptable to the patient, consider other treatment options, including perhaps salvage surgery with biologic therapy, if that's possible. Additional short course of systemic glucocorticoids or systemic corticosteroids which are not preferable, but I think it's a discussion that you have to have with your patient. And after 6 months, if the patient really is not responding to the therapy, I think it is important to consider stopping the medication and switching to another biologic. So defining response to biologic therapy after 12 months of treatment. So you see this patient back after a year, and I still think that those outcome measures are important, and these are some tools that you can use to assess how patients are doing, including a nasal polyp score, which you would have to do with a nasal endoscopy, nasal congestion score, VAS not 22, and perhaps even an upsit, just to see how their smell is doing, if they still feel like they're not smelling as well as they should be. Furthermore, there should be no need for more surgery or systemic steroids. And as you can see here, if the patient is still doing well, then you can continue with the biologic treatment. But if they're really not improving on any of these outcome measures, perhaps consider another biologic drug or offer the patient a surgical option. So going back to our patient Jim, we know that he has both asthma and CRS with nasal polyps. And the best course of action would be to determine his asthma phenotype, to see if he has allergic or eosinophilic asthma. Oftentimes, patients who have elevated eosinophils and elevated IgE, it's hard to differentiate what type of biologic would be best for this patient. And as of now, in the United States, we have both Dupilumab and Omelezumab approved for treatment of CRS with nasal polyps. In my opinion, if a patient has very significantly elevated eosinophils, perhaps over 10%, an absolute count in the thousands, it might be wise to try Omelezumab, but I find that patients who are treated with Dupilumab have significant improvements in their sense of smell quite quickly, and that's why it's important to talk to your patients and see, what is their symptom that is most bothersome to them. If it really is their, loss of smell and their nasal blockage, I think Dupilumab is a great option for these types of patients. And of course, for comorbid asthma, we know that patients who have both the polyps and asthma do worse overall with any modality, and especially for surgery and for systemic corticosteroids. So in these types of patients, a biologic would be more appropriate. You have chosen a scenario with a decision point of determining what type of medical treatment is appropriate for Jim, and a complicating variable of AERD. AERD comprises CRS with nasal polyps, asthma, and intolerance to inhibitors of the COX-1 enzyme. Prevalence of AERD among patients with CRS nasal polyps has been reported to be 16%. Traditionally, therapies for AERD include the use of leukotriene-modifying agents, as well as aspirin desensitization therapy, which has shown to be a useful adjunct and associated with improvement of cystinyl leukotrienes and IL-4 levels. There remains a subset of patients with AERD in whom these measures are not efficacious, and in these groups of patients, biologic treatment may be an option. Dupilumab has been shown to be effective in treatment of patients with AERD. In a 6-month single-blinded trial of Dupilumab in patients with AERD and uncontrolled CRS with nasal polyps, patient received 4 weeks of placebo followed by 24 weeks of Dupilumab. Primary and secondary outcomes were measured, as you can see here, and SNOT-22 improved significantly from baseline to 6 months, and the secondary outcomes also improved. Dupilumab was highly effective as an add-on therapy for CRS with nasal polyps, especially in these AERD patients, improving patient-reported outcomes, imaging, as well as markers of type 2 inflammation. Omelezumab has also been shown to be effective in patients with AERD. In this study, outcomes were measured among patients with AERD 6 to 12 months before receiving Omelezumab, and during the last 6 to 12 months they were on Omelezumab. Among the outcomes evaluated include number of oral steroid courses as well as short-acting bronchodilator use. 62% demonstrated reduction in number of steroid courses and number of short-term bronchodilator canisters used during the last 12 months on Omelezumab. Patients with AERD and concomitant IgE-mediated respiratory disease showed a statistically significant reduction in the number of steroid courses and the number of use of short-acting bronchodilators while on Omelezumab for 1 year, whereas those without concomitant IgE-mediated respiratory disease did not have a substantial reduction. Other biologic treatments are in the pipeline and may be useful in patients with ARD, such as Benralizumab and Mepolizumab. Both are approved for asthma and are also being evaluated in CRS with nasal polyps. Benralizumab is an inhibitor of the anti-IL-5 receptor and has been approved for the treatment of severe asthma with an eosinophilic phenotype. This medication is currently in phase 3 study for the treatment of CRS with nasal polyps and has recently completed enrollment. So going back to our patient, Jim, at this point, Jim can be potentially treated with a biologic therapy such as Dupilumab or Omelezumab. And the question is, should we also talk to our patient about aspirin desensitization? I think that in all of our patients, we should provide them with all the options available, including aspirin desensitization. And this therapy has been shown to be effective in certain subpopulations of patients with AERD. However, I think it's also important to discuss with the patient that there may be potential side effects of aspirin long-term, and that patients cannot stop aspirin without the sustained benefits of the desensitization. You have chosen a scenario with the decision point of determining if Jim would benefit from surgery to remove his polyps, and a complicating variable of Jim being eager to have surgery to cure him of nasal polyps. Treatment of CRS with nasal polyps is complex. The disease is a chronic one, and it's often refractory to medical and surgical treatment. It requires long-term medical management, and medical management may not be effective for severe inflammatory disease. Surgery may be needed to remove nasal polyps in conjunction with medical treatment. Functional endoscopic sinus surgery, or FESS, is a useful treatment option for patients who have CRS with nasal polyps, especially when medical treatment is unsuccessful. And the goals of surgery are not curative, but it is important to counsel patients that when we do functional endoscopic sinus surgery, we are allowing for better access for topical therapy, we're decreasing the inflammatory load by removing the polyps, decreasing the eosinophil burden, and the surgery should be tailored to each patient. Also important to keep in mind that after surgery, patients need to be on a post-surgery maintenance therapy with topical steroid delivery, or polyps will routinely return. Polyp recurrence is common after sinus surgery. Results of studies have shown that recurrence of nasal polyps are as high as 35% 6 months after surgery and 40% 18 months after sinus surgery. And patients who have had surgery and do not want another surgery often continue to suffer from poorly controlled inflammation. Type 2 inflammation is clearly associated with more severe sinus disease and symptoms and recurrence after FESS, or functional endoscopic sinus surgery. Going back to our patient, we explained to Jim that although surgery may be beneficial, relieving his symptom severity, improving his quality of life, surgery will not cure his nasal polyps, and that the polyps are likely to recur afterward, especially if he's not completely adherent to his postoperative medical regimen. And sometimes additional surgery is needed. Further, as I mentioned, if surgery is done, it should be done in conjunction with a twice daily medical treatment regimen with topical steroids and nasal saline irrigations. You have chosen a scenario with the decision point of determining if Jim would benefit from surgery to remove his polyps, and a complicating variable of Jim having comorbid asthma. This is a slide from the multidisciplinary Euphoria Expert Board meeting, and it's important to realize that patients who often have CRS with nasal polyps as well as asthma often benefit from the multidisciplinary care of not only the otolaryngologist and the allergist, perhaps, but even a pulmonary specialist and the primary care provider. So these patients are complex, and both the upper and lower airways need to be managed for patients to have the best outcome. And oftentimes, as we had discussed, patients with both CRS with nasal polyps and asthma have the highest incidence of recurrence after sinus surgery and oral corticosteroids. The goals of sinus surgery here include removal of nasal polyps to reduce the inflammatory burden and decrease nasal obstruction, but to also allow for better access for topical therapy. And as you can see here, post-surgery maintenance therapy with intranasal topical steroids and irrigations are critical in order for the patient to continue to have a successful outcome post-FES. As you can see here, patients who have asthma have the highest rate of recurrence, and this is on the bottom part of the slide. As you can see here, the patients who have the severe type 2 type of inflammatory disease with the nasal polyps, and I would include here also AERD or NSAID ERD. The recurrence is quite high, and these are the patients we struggle with the most. So we explained to Jim that even after surgery, he may experience recurrence of nasal polyps. In addition, his underlying asthma still needs to be addressed. You have chosen a scenario where the decision point of determining if Jim would benefit from surgery to remove his polyps and a complicating variable of Jim also having AERD. And especially in these patients who have AERD, it is often wise to incorporate a multidisciplinary approach, which means treatment not only from the otolaryngology perspective, but also including our allergy, immunology, and pulmonary colleagues, and our primary care providers. The goals of surgery for an AERD patient, similarly to a patient without AERD, are similar, but must be tailored to that patient. And the goals are to remove the inflammatory load, remove the eosinophils and the other inflammatory effectors, remove the polyps, allow for better access for topical therapy. And also post-surgery, very important that the patient continues on maintenance regimen with intranasal corticosteroids and saline irrigations. In the AERD population, these patients represent the most severe inflammatory endotype. And these patients may benefit from a more extensive surgery in general. Draft 3, which involves more extensive frontal sinus surgery, may be effective and can help reduce the recurrence of polyps and the need for revision surgery in patients with AERD, likely due to increased topical access for irrigations and topical nasal steroids. However, patient selection is critical because every patient has particular anatomical and disease-specific criteria that need to be considered prior to making the decision to do a more extensive surgery versus a more traditional functional endoscopic sinus surgery. Going back to our patient, we explained to patient Jim that the risks associated with surgery and that even with a successful surgery, he may experience recurrence of nasal polyps. In addition to maintain any quality of life improvements, he will need topical intranasal steroids as well as saline irrigations, along with potential post-surgical aspirin desensitization. And as I mentioned before, aspirin desensitization is followed by a long-term daily aspirin regimen. And patients cannot stop aspirin without having the sustained benefits of the treatment. In conclusion, CRS with nasal polyps is usually characterized by type 2 inflammation and often occurs comorbid with asthma. Type 2 directed biologic therapies approved for both asthma and CRS with nasal polyps include Dupilumab and Omelezumab, with others in development. These therapies can reduce nasal polyp size and improve quality of life. CRS with nasal polyps is often refractory to traditional medical and surgical treatment and tends to be more severe in patients with AERD. Surgery in this population may need to be more extensive, and patients should be selected carefully. Biologic therapies such as Dupilumab and Omelezumab may be beneficial in this patient population, along with aspirin desensitization. Goals of surgery for patients with CRS with nasal polyps include the removal of nasal polyps as well as opening all of the sinus outflow tracts to facilitate the delivery of topical medication. However, surgery cannot cure nasal polyps. Polyp recurrence is common, and it should be explained to patients that additional surgeries may be necessary along with ongoing medical treatment, such as topical steroids and saline irrigation. Additionally, underlying comorbidities such as asthma and AERD will continue to require treatment.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ERM860. This activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.